Hello, I'm Samia Rashid. I'm a breast and gynae pathology fellow at Hamad Medical Corporation, Qatar. I'm presenting this poster, giant fatal squamous cell carcinoma arising in a teratoma in a young lady. It's an unfortunate case of a 24-year-old lady who presented with an abdominal mass. Upon investigation, this was thought to be a dermoid cyst or ovarian mature cystic teratoma. Other than race CA125, there were no features of malignancy or any other lesions, or even signs of any rupture. So this race CA125 was attributed to intralesional bleeding. Intraoperatively, the mass measured 10 centimeter. It was adherent to the posterior wall of uterus and it ruptured during surgery. This is what the mass looked like. It was 10 centimeter, it was ruptured, it had this solid cystic appearance, some purulent areas and hair shafts. So it could be something as mature cystic teratoma. But under the microscope, it had a surprise for us, and I have these keratin pulse and moderate to very well differentiated squamous cell carcinoma. These are some other areas, and I also had some colonic epithelium and other features of mature cystic keratoma. Also, along with that, I had carcinoma in situ, ruling out metastatic squamous cell carcinoma. After the surgery, she was discharged. There were no complications, but after 1 month, she presented to the clinic with abdominal pain. A CT scan of abdomen and pelvis was done that showed multiple pelvic and abdominal abscesses and a large collection in the pelvis. An exploratory laparotomy showed purulent material in the peritoneum, along with multiple peritoneal and omental nodules. The sigmoid colon was adherent to the uterus, but there was no rupture. The pelvic abscess was drained, and an abdominal omental biopsy was done from these nodules, and it was later histologically proven to be metastatic squamous cell carcinoma. This patient remained unstable and was subsequently diagnosed with septic shock. 18 days after the second surgery, the patient developed perforation in the sigmoid colon with fecal output from drains. A family meeting was arranged and her condition was discussed in detail with her and her family, and a decision for DNR was reached. Squamous cell carcinoma is the most common somatic malignancy arising in a mature cystic teratoma. However, most of these are incidental, organ confined, and associated with a good prognosis. Some have even been treated with just unilateral salpingo-oophorectomy. In the literature, the most fatal and aggressive diseases that we see, these were in elderly women with advanced disease at initial presentation. We think that there can be two explanations for this lady's fatal short clinical course. The first one is that she had an advanced disease since the beginning. So the reason that she had CA125 is because she already had disease in the omentum, and we failed to pick it during our pre-op investigation, which was limited because we believe that this is just a mature cystic teratoma. There was no radiological signs of malignancy in this lesion. The second and more favored explanation is that it was actually the rupture of the tumor during the first surgery that gave rise to pus tumor in the peritoneum, and it's this inflammation and development of these adhesions that led to sigmoid perforation or rupture that had a more pronounced effect in her survival. Take-home message from this case is that the tumor rupture may be a way more important prognostic factor than any other thing, and that any mature cystic teratoma, especially the ones with large size, should be appropriately investigated. So that was it. If you have any questions, do let me know.